Thank you all for being here. It's my pleasure to talk to you a little bit about some ankle injuries. When I was tasked with this, I didn't know when I was going to do it during the day, and I thought maybe we'd talk about some diabetic foot stuff, but given that it's right before lunch, we'll talk more about acute ankle injuries here. So I do have a disclosure. I do some consulting for Acute. It has no relevance with regard to this talk. So as far as the goals for today's presentation, first of all, I want to get us all on the same page, talking about some basic ankle anatomy and basic ankle radiography. We'll talk a little bit about how we evaluate initially an acute ankle injury and some of the management strategies there. And we'll talk about some of the more common injuries, such as ankle sprains, Achilles ruptures, and then a little bit about what else could it be. Someone came in with an ankle injury, we thought it was a sprain, but it just doesn't seem to be getting better. What are the things we need to look for as far as that goes? So as far as basic bony anatomy of the ankle, there's three basic bones that make up the ankle joint. The first is the big shin bone, the tibia, and it has a couple of different structures associated with it. One that is commonly associated with the ankle injury is the medial malleolus, as well as in the back is the posterior malleolus. The tibia is the main weight-bearing bone of the lower leg. It takes between 80 and 90% of the full body weight. Whereas the other bone, the fibula, takes somewhere between 10 and 20% of the weight, but is really involved more in stability of the ankle, and we'll see that there are a lot of ligamentous attachments associated with the fibula that can cause some problems for us. The most distal extent of the fibula is called the lateral malleolus. The bone that sits underneath these is called the talus. This is a very important bone in foot and ankle mechanics. It basically attaches the lower leg to the foot. It is about 80% covered in cartilage and susceptible to injury due to this. It's got a bit of a special geometry, which we'll talk a little bit about with regard to sprains, in that it's a little wider posteriorly, and therefore when we plantar flex, we have, a little narrower posteriorly, so when we plantar flex, it's more susceptible to instability. And that's why most people, when they sprain their ankles, will be going downhill rather than uphill. So talking about some of the ligaments of the ankle, we'll start with the lateral side here. The most commonly injured ligament in the lateral ankle is the anterior talofibular ligament. This is a ligament that is taut when the ankle is in plantar flexion and inversion, which is the most common way we injure our ankles. Another lateral ligament structure that often gets injured when we invert our ankle is called the calcaneofibular ligament. And as the name suggests, this attaches the calcaneus to the fibula. It is tight when the ankle is in dorsiflexion and inversion. On the medial side of the ankle is this very large ligament called the deltoid. It's got a few different components, and it attaches from the medial malleolus to the talus, as well as the navicular and the calcaneus. This is a very stout ligament, and it's uncommon to injure this, both because of its incredible strength, but also because of the bony anatomy of the medial malleolus. Now there's this kind of interesting structure that connects the fibula to the tibia that's called the syndesmosis. The syndesmosis is comprised of three basic structures. The one in the front is the anterior inferior tib-fib ligament. The one in the back is posterior. And then between the two bones that runs up and down the lower leg is called this interosseous membrane. Injuries to this area are what we refer to as a high ankle sprain. Moving on towards some of the tendons and muscles about the ankle, we usually will divide the structures in the lower leg into various compartments. So starting anteriorly, we have our structures that help dorsiflex the ankle and the toes. The anterior tibialis helps to actually invert a little bit, but also mostly serves as our dorsiflexor of the ankle. And then some of the toe extensors cross over the front of the ankle as well and can be involved in some of these injuries. Laterally, we have our dynamic restraints to inversion injuries. And these are the peroneals. Both the peroneus longus and the peroneus brevis serve to hold our ankle against these inversion injuries. When we have an ankle sprain, oftentimes we find that the peroneals are somewhat weak and are not protecting our ankle appropriately. On the medial side of the ankle comes the components of the deep posterior compartment of the lower leg. These are our toe flexors and this big tendon called the tibialis posterior. The tibialis posterior helps to plantar flex and invert our foot. It's also a very important stabilizing structure to the arch. And we see people with problems with this who have a very flat foot. Posteriorly, there's one main tendon, and that's the Achilles tendon. This gets its muscle control from two basic big muscles of our calf, the soleus and the gastrocnemius. There's also a small vestigial tendon called the plantaris. It doesn't serve much of a role in injuries about the ankle, though sometimes the hand surgeons will use it to repair tendons in their line of work. So a quick word about radiographs of the foot and ankle. Now, a lot of these injuries, these acute injuries, people don't want to put weight on their ankles, so I understand getting non-weight bearing films, and I do this, when I'm concerned about a fracture. But if people come walking into the office, I find it very important to get weight bearing views. It gives me an idea of the alignment of these people when they're doing what they normally do, which is walk. You can see on the pictures here that the top one is without weight bearing. There's a bit of an arch there, and then as the person weight bears, there's really no arch on it. I also don't see much of a role for obtaining two-view x-rays. These are pretty complex three-dimensional structures, and I need all the help I can get for some of these diagnoses. And so I think 3 views is generally standard of care, both within the foot and the ankle. So looking at plain ankle radiographs, I'll start on the lateral view on the far side there. Some of the things I use this x-ray to look at are, it's often that spurs will show up on these, both in the Achilles as well as over the front of the ankle. I look at general alignment. The talus bone should sit nicely under that tibia bone. In conditions associated with instability, you will sometimes see how the talus slips forward, and that gives me an idea about a particular ligamentous injury. The middle view is the straight AP view of the ankle. This one is very important to look at the medial structures of the medial gutter here, where the tibia and the median malleus articulates with the talus. This should be a nice, smooth, articulating surface. It should have symmetry between this as well as the top of the talar dome there. The mortise view is taken at 30 degrees of internal rotation, and it allows us to see the joint basically in its full view. And again, I'm looking for things like symmetry. Are the joint spaces the same across, or is one wider than another, indicating that there's been a ligament injury or potentially a bony injury causing the talus to shift within this area. You can also see on this view that we can see the joint under the ankle. This is called the subtalar joint. And sometimes in injuries to the talus or the calcaneus, this will show up on these ankle x-rays. So moving on to acute ankle injuries, I first start with a very thorough history, and I find a lot of information can be learned from this, and it really directs my physical examination. I see mostly inversion injuries of the ankle. Again, that tends to be because of the geometry of the ankle. Again, that will direct kind of where my focus is with my physical exam. Eversion injuries occur, like you see Francesco down here, where the foot is planted and eversion force is placed on the ankle. These tend to be a little more severe. This is the mechanism that will lead to a high ankle sprain or sometimes even worse injuries to the syndesmosis. The other mechanism I see a lot is this eccentric contraction where someone is pushing off, oftentimes tennis or basketball where they're making a sharp cut, and this is the force that will create an Achilles tendon rupture or potentially a calf tear or something like that. And again, establishing a good history of these injuries really drives my physical examination. I think it's important to establish the level of energy involved in these injuries. Is this a simple, I twisted it off a curb, or did I fall 20 feet off a scaffolding? The latter case, where someone has a very high energy injury, I will often be a little more meticulous about evaluating an x-ray that comes in where it's red as not having any fractures or anything like that. And we recently had a case where someone fell off a scaffolding and the x-rays were read as normal. The person was very swollen and painful. And in those cases, you look very carefully, you can see some minute detail that indicate a more severe injury. Contact versus non-contact is also something I ask people about. It seems to be more severe injuries can be related to a contact than non-contact. People will often describe sounds associated with their ankle injuries, usually a pop or two. Sometimes this does indicate a more severe injury, and oftentimes an Achilles rupture, people will tell you they heard it go. So this is something that I do ask people on a regular basis, and sometimes contributes to their management. In my office, it's very important to establish whether or not this is a first-time occurrence or something that's happened multiple times over the course of their lives, indicating that they have a certain degree of instability within the ankle. And then the ability to weight bear plays a strong role here as well, and we'll talk a little bit about obtaining radiographs and where the ability to weight bear falls in that discussion as far as the Ottawa ankle rules, looking at radiographs. So on physical examination of some of these injuries, the first thing I start with is inspection. I look for signs of swelling, signs of bruising, and it helps me sometimes to determine where exactly this injury has occurred, though oftentimes it's so diffuse that it's not necessarily helpful as far as localizing things, but it does give me an idea of the severity of the injury. Obviously, is there any deformity to the limb, any wounds or abrasions that would suggest a more severe injury? I do find palpation to be very helpful in these injuries, and I encourage patients to use the one finger rule, which is show me where you hurt with one finger, because oftentimes they'll tell you, well, I hurt somewhere around here, and that's not particularly helpful for me. As well as a physical examiner, I can pretty much isolate different structures within the ankle based on one finger. You do have to kind of know a little bit about surface anatomy of the ankle, and sometimes we get these injuries coming into our offices that are just massively swollen, so it can be a little difficult to palpate immediately, which is why I oftentimes will have people come back fairly quickly, a week or two out from these things, so I can get a better idea of where exactly their injury has been. And this is also what saves us from doing additional imaging, spending money on things like MRIs that you don't necessarily need in some of these cases. Bony tenderness is very important in injuries about the ankle. So some of the landmarks on the lateral aspect of the ankle I look at. I think it's very important always to palpate the Achilles tendon posteriorly. A missed Achilles tendon rupture leads to pretty poor outcomes. And so, I do use my history to guide me on this, but it's a very easy thing to just kind of palpate, make sure that Achilles is intact. Moving forward from this, there's the peroneal tendons that wrap around the fibula. You can see in this picture, actually, that person's peroneal tendons are quite easily visible, not always that case, but certainly can be injured in any sort of an inversion type sprain. Anterior to this is the lateral malleolus, the distal extent of the fibula. Again, bony tenderness is an important thing to establish, especially if we're going to use our physical examination to drive our imaging studies. Anterior to this is the most commonly injured ligament, the anterior talofibular ligament. Oftentimes this is the one that people present with injury to when they're coming in with these lateral ankle sprains. I also see a lot of people who have an inversion injury to their ankle, and they come in with ankle x-rays that were taken in the emergency room, but they're tender over their fifth metatarsal because it's the same mechanism that creates fractures of the fifth metatarsal. So important to also palpate this when we're first evaluating these people. As well, working our way up the leg, particularly with these injuries where they might involve the syndesmosis or there's an eversion moment to the ankle, palpating the fibula up and down can sometimes elicit pain in the proximal fibula, which can be associated with a fracture. It's an injury that we'll talk a little bit about later, but oftentimes there's some distracting pain of the ankle where they don't recognize that actually, I do hurt my proximal fibula. Moving to the medial side of the ankle, there's relatively fewer structures here to palpate. Obviously, the medial malleolus is important, and again, looking for this bony tenderness to indicate a possible fracture in this area. Again, palpation of the Achilles tendon. A common other place that people will have pain just generally, and I'm going to be around for the physical examination. We'll talk about these things, but the plantar fascia is more of a medial structure and can be palpated here as well. So I always do it, as extensive a neurovascular examination as I can. Again, these people with these acute injuries, sometimes it's tough to feel pulses because they're so swollen. But you just want to make sure that their toes aren't black or something like that. Hair pattern can give you an idea if there is some form of vascular compromise to this limb. Neurologically, I do have a fair amount of people who come in after an acute injury to their ankle who tell me my foot feels numb. I think there's a few reasons for that. One is just simple stretching of the nerves with this type of an injury. The other is swelling. The other is immobilization. The nerves just don't like it when we hold things still for a while. The other reason why this neurologic examination is important is the people who have dense neuropathy. These people can get a sprain like this that can lead to kind of disastrous results and further degeneration of the joint because they just can't feel things. And I've seen people turn pretty quickly from an ankle sprain where there was no changes on the x-rays to where they really destroy the whole joint just because they've got neuropathy so bad. So I do try and get people to move it a little bit, even when they're broken, to try and get an attempt at a motor examination. Often they don't give me a whole lot, but if I can have them even circumduct the ankle a little bit, that tells me a lot about the functioning structures. I think it's also very important for everybody to know that you can still plantar flex your foot despite having an Achilles tendon tear. And it's similar to Dr. McCarron's talk on a biceps tendon injury because there are these soft tissue attachments even around the tendon. They can still allow that, as well as a few other structures that will plantar flex. So it's very important, again, to not rely on simple motor examination of an Achilles tendon for a full evaluation. So you've done your physical examination. What's the role of x-rays? Well, we get a lot of x-rays of ankles that are completely normal after an injury. And so up in Canada, where maybe they're a little more cost conscious than we are here, they established this technique called the auto ankle rolls. And what this relies on is upon physical examination to determine if there's any bony tenderness. And what they look at is the posterior edge of the fibula, the posterior edge of the distal tibia, as well as the fifth metatarsal or the navicular bone. Tenderness in any one of these positions demands an x-ray in their system. In addition, they look at is the patient able to bear weight immediately after the injury for 4 steps or in the emergency room for 4 steps? And the original studies showed that they could decrease unnecessary x-rays by about 35%, which is great. And I think that trying to limit costs in healthcare is obviously an important thing. The reality is that someone who comes in with a swollen ankle, despite whether or not they're really tender, probably demands an x-ray. And so it's pretty much 0% people in my clinic who come in with an ankle injury that don't get an x-ray there. Now, again, this is where your physical examination comes into play because these x-rays show different parts. And so if someone is tender over the 5th metatarsal, that's not really going to show up on a set of ankle x-rays. So very important to get foot x-rays. Same with the proximal fibula. And this is where you really have to palpate it, because oftentimes these people with these syndesmotic injuries don't necessarily hurt up at the fibula. And so you got to have a bit of an index of suspicion and good physical examination. Now, a word about advanced imaging. I don't find it tremendously helpful in the acute setting unless there's something obvious that I'm looking at. If I'm worried that a tendon is dislocated or I see some changes on the x-ray where I'm worried about a cartilage injury, I don't find much of a role of advanced imaging, at least in the acute phase. Now, and as well, there are certain sequences that I like to obtain as people are able to give me a little more history. So I find that early follow-up is much better at establishing where exactly these injuries are. Now, this does change a little bit depending on whether this is a work injury, as some of the other guys alluded to, and oftentimes I'm a little more aggressive about getting advanced imaging fairly quick in the workers' compensation case to assure that yes, you're going to be okay going back to work. No, you don't have a cartilage injury or a torn tendon or something like that. But that's a little bit of a different situation there. So let's focus a little bit on the most common injury, which is an acute lateral ankle sprain. This is an injury to usually both the anterior talofibular ligament as well as the calcaneofibular ligament. And again, this is caused by an inversion force on the ankle. There's a lot of these per year, and it costs a lot of money to take care of them, as well as in time lost, up to $2 billion by some accounts. It's the most common injury sustained in sporting events, where it accounts for about 30% of all sporting injuries, and half of all ankle sprains will occur during sporting activities, with basketball being a fairly high proportion, followed by football and soccer. Now, there are a couple of special tests to look at the stability of these ankle ligaments. Now, in the acute phase, for one thing, these don't feel great on someone who has just torn their tendons. And the other thing is, I don't know that it really guides treatment early on, although it can give you a sense of how severe the injury is. So, and I'll talk a little bit about these injuries or these special tests in the physical examination part, but essentially the anterior drawer test is testing this anterior talofibular ligament, trying to basically pull the talus forward from under the tibia by directing an anterior force while holding the lower leg. The talar tilt exam is testing both the anterior talofibular ligament as well as the calcaneofibular ligament, again trying to open up the lateral side of the ankle. These are tough tests to really feel, and even in my own hands, I'm oftentimes misled by someone who has a lot of play in the joint under their ankle and the subtalar joint. And so when I'm worried that someone has had these chronic sprains and that they've got this chronic instability thing, I'm almost always getting actually a stress x-ray, where I actually will do these examinations under an x-ray to be sure that I'm feeling what I think I'm feeling, because we can be really easily misled into thinking that someone's unstable when in fact you get the x-rays and they're not. So we do have a grading system as far as lateral ankle sprains go. Grades from 1 to 3. Grade 1 is generally just a stretching to the ligaments. There's not a lot of swelling that occurs with these. Usually people are able to bear weight. Whereas a grade 3 represents a complete rupture of both the calcaneofibular ligament as well as the anterior talofibular ligament. A lot of swelling, a lot of bruising associated with these, and oftentimes people do have difficulty bearing weight. Now, in the acute management of these injuries, I don't know that these really play a role, but it may guide this discussion about return to play as far as recovery goes, because obviously a grade 1 sprain is going to take less time to get better than a grade 3. So how do we initially treat these injuries? Well, I think RICE is the first thing to do: rest, ice, compression, elevation. I also do believe that some form of immobilization will help these patients feel better. There's a few examples here, such as a stirrup brace or a lace-up brace or even a boot. But we have to be a little careful about using these things in the acute phase, because prolonged immobilization can actually cause more problems than good it's doing. I do see patients who come to me who probably more because of their own discomfort have kept the ankle still for so long that things have become stiff, and they've developed sort of neurological sequelae because of that. In the worst case scenario, it's like a complex regional pain syndrome type situation. So I really encourage these people to move their ankle as much as possible. Even when they're in a boot, I tell them, come out of that thing at least a few times a day to move your ankle around. It's not going to cause more damage to the ankle, but certainly keeping it immobilized for longer will. I tend to use these lace-up braces most. I think they provide stability, but also people can generally move their ankle a little more than the other ones. Now, what about the role of physical therapy in an acute ankle sprain like this? Well, in the long term, it seems to be that really people get to the same place eventually. But I think physical therapy can get people moving along a little quicker, a little faster, potentially returning to sport and activity a little earlier than may be. However, a home exercise program will lead them to the same eventual result with these. So what about returning to sport? So it really depends upon the severity of the injury, but also the activity the person is trying to get back to. These grade 1 sprains, they may be able to play on it right away, or maybe take a week or two off. Whereas a grade 3 sprain is going to take a long time. And while most people would say, well, it might be a month or 2 months before you get back after one of these really bad sprains, people stay symptomatic for a lot longer than that. The ankle will be sore, for a grade 3 sprain, even up to 6 months or longer after that. As far as what people wear when they're returning to activity, there's some studies looking at bracing versus taping, and generally provide about the same degree of stability. Some of the studies suggest that taping will loosen with time. I don't have a big preference, except for maybe sport specific. Sports that involve kind of more minimalist shoes, track and field, ballet, soccer. These are things that don't tolerate a very bulky brace. And so oftentimes the only option here is taping. I also often will get the question, I'm using this thing every time I play. Is it making things worse, or am I getting weak from that? And the answer is no. It does not provide that much of an immobilizing force that it's going to cause a long-term problem there. Now, when I have an individual in my clinic who's a ways out from their ankle sprain. They're asking me, well, is it okay to go back to activity? I think the thing that probably provides me the most information is their functional ability. And one simple test I use is their ability to basically stand on a single limb or hop on a single limb. And if they can do that without much discomfort, then I think they're probably good to go. Now, a little adjunct to an ankle sprain are these avulsion fractures. So we'll often see this avulsion to the lateral malleolus like this. So essentially, this is a grade 3 sprain, and I treat it the same way. Basically, instead of the ligament being ruptured mid-substance, it's pulled off a little bone with it. Generally, it doesn't have a different recovery than a bad sprain. And again, I treat it the same way with the Rice therapy, early range of motion, and bracing. It's pretty rare that I have to go in and do something to that piece of bone or ligament that's attached to it. So that's our standard ankle sprain. The high ankle sprain is a little bit of a different beast here. So again, this is usually an eversion injury, and as you can see in this individual, they've caught their foot on the ground, but it's sustained this external rotation force to the lower leg. This will result in an injury to these syndesmotic ligaments and also potentially the deltoid ligament on the inside. These people will present with pain sometimes on the inside of their ankle, but if they don't have an injury to this deltoid ligament, that pain will show up between the tibia and the fibula in this interosseous space. And there's a test we use to look at that. It's called the squeeze test. So what this is compressing the fibula and the tibia together around mid-calf. Pain with this examination generally corresponds to a syndesmotic injury, especially in the right situation. And this is what is commonly referred to again as the high ankle sprain. Now, there's varying levels of severity to this injury, and an injury to the syndesmosis that goes all the way from the proximal fibula down and then can sometimes exit the medial side of the ankle leads to a much more unstable situation and one that often requires surgery. When it breaks the proximal fibula up here, or like here, again it can be fairly subtle, we refer to that as a Mason-New fracture because again the force is generated all the way down this interosseous membrane and exits out here. And you can actually see people can avulse their deltoid ligament right here, or just that they've torn it completely and now you see this widening there. This is an injury that if you leave it will lead to fairly rapid arthritis, and so this is an injury that almost always necessitates surgery to put that back together. Now, if you don't have a medial injury, it's still important for these people to know that the recovery time is quite a bit longer than a standard ankle sprain. So, I will see people in my clinic who just aren't getting better from their ankle sprains. They're not able to bear full weight in an appropriate time frame, or things are just staying too swollen and too painful for too long. X-rays around the ankle can be very subtle. There's a lot of these ligamentous and tendinous attachments. And so here's a few things that can linger when the X-rays don't really show anything. Now, the one thing I want to make sure you all don't miss is an Achilles tendon rupture. Again, people believe that when they rupture their Achilles tendon, they shouldn't be able to move the foot, they shouldn't be able to put weight on it. When the reality is after an Achilles rupture, within a few days, people generally don't have severe pain and can generally bear weight. And for people who aren't used to having an injury, which is oftentimes who these occur in, some of them will try to walk it off. I would encourage you to always palpate that Achilles tendon if you see someone in the clinic with kind of a chronic ankle problem. What happens with delayed treatment of these injuries is that the tendon lengthens and then the skin actually will atrophy somewhat around it and leave this kind of dimple in it here. That's a major problem for trying to get these things back together, because if I do surgery on an area where the skin is really contracted and I try to fill that up, that leads to some pretty bad wound problems, particularly around these. And then people who spend a lot of time after their Achilles injury will atrophy their muscles, and it's very tough to get a good result with a chronic Achilles rupture. Oftentimes I'm using things like allograft or tendon transfers to try and serve the purpose of this Achilles tendon that I just cannot repair. I have been able to repair subacute ruptures up to about 3 months out, but that can be very difficult. So the sooner that we get these people in, if they indeed want surgery, then the sooner we can get them moving. Now, there are some special tests that we look at as far as Achilles ruptures go. I always get these patients prone, and there's a few reasons. One is because, as you see in the picture, their resting tension will lead to more dorsiflexion on the affected side. You can also see pretty clearly the outline of the Achilles tendon. And lastly, there's this test called the Thompson test. What that is basically squeezing the calf when they're prone. If there's no attachment between the calf musculature and the heel bone, then there won't be any movement in plantar flexion of that ankle, and that's a positive test. I'm generally not getting additional studies if I find these particular things, because they're so sensitive, so specific for this injury. I do usually get an x-ray of the lateral ankle, though, in these cases, because sometimes what happens is the Achilles isn't torn in its mid-substance. It sometimes rips right off the bone. And that's something I like to know because generally that doesn't do well with non-operative management, like actually an Achilles tendon rupture can. So over the last decade or so, there's really been an evolution as far as management of Achilles tendon ruptures. People have come up with these new functional rehabilitation protocols that seem to lead to basically equivalent results with surgery. Now, still, athletes, people who want to get back as quickly as possible to their athletic endeavors, will generally opt for surgery, and I always give people the option of what they want to do. We think we can get them moving a little faster with surgery, potentially back to sports sooner, especially in those people who make a living based on their ability to run and jump. But some of the later evidence suggests that re-rupture rates are actually about equivalent with non-operative management compared to operative management. And actually, I think it's very hard to find someone to repair your Achilles tendon right now in some of these socialized medicine countries. I know up in Canada, it's very rare for them to do surgery on an Achilles tendon rupture. So I always talk with people about this. A lot of my younger patients will still opt for surgery, wanting to get back to sport as quickly as possible. So what other injuries are important not to miss? Well, like I said, this talus has a whole bunch of different attachments to different joints, and there are all sorts of injuries that can occur around this. This here is a very subtle sign that is sometimes picked up on an x-ray, but not often, and it's the lateral process of the talus. The problem with that injury is that it involves this joint under the ankle, the subtalar joint. And you can see here, this is actually a pretty big chunk of bone on a CT scan that doesn't really show up great on an x-ray. And there's no great x-ray view that's going to make that. So that's where really physical examination comes into play. That's where your index of suspicion, again, is this a high energy injury that might create that? Or is this patient just really tender in this one spot right over the lateral hindfoot? I've also seen talar neck fractures. You can kind of see this here. Again, very subtle. People who have spent, weeks on end trying to put weight on their foot. They were told X-rays were normal, but then they come in with this thing, and this is a bad injury. Again, because of the special blood flow of the talus, which comes down and then actually loops back around. So you can actually cut off blood supply to the rest of the talus, leads to a major problem with avascular necrosis. Inversion injuries can also cause fractures to the heel bone, to the calcaneus. And this is actually more on the range of an avulsion type injury. There's a big ligament called the trifurcate ligament that attaches to the anterior process of the calcaneus. Now again, it's not something that we're generally looking for when we get ankle x-rays, but it's important that if you don't see a fracture anywhere and someone comes in with a very big, swollen, bruised ankle, that you really try to look at this area. This is the only view, though, the lateral view of the ankle, that'll show this anterior process. And I don't know, I hope you all can appreciate that there's a small crack to this. Now, I generally will treat these non-operatively. Usually keep people in a boot for anywhere from a month to 6 weeks or so. But I do have to follow them along because sometimes these don't heal and sometimes cause instability. Now, if it's a big fragment that involves a lot of this joint here, sometimes I will do surgery to put it back in place. This last injury involves the tendons on the outside of the ankle, these peroneal tendons. So again, this tends to be an inversion type force. And again, x-rays are very subtle for this injury. So you got to have an index of suspicion. You got to palpate these peroneal tendons. Sometimes you'll see this little fleck on the outside of the fibula here that indicates that the sheath around these tendons has been torn. These people will have pain kind of over the posterior lateral aspect of their ankle. And oftentimes, when they move their ankle in a circle, when they circumduct their ankle, you'll be able to feel something popping. And occasionally, you'll get this frank dislocation here. Very rare does this get better on its own. And if I catch these early, sometimes I can just repair that bone back down to bone, which heals a little better than if I have to reconstruct the ligament there. So that's essentially it. There are a couple of injuries, like this talus osteochondral lesion, that can also lead to persistent ankle pain and swelling. This will produce mechanical symptoms within the ankle, things like catching, locking, the sensation that they just have something stuck in their ankle joint. Won't necessarily show up on an x-ray. So someone comes in, it's a couple of months after their ankle sprain, they say it just keeps doing this, clicking or this sharp pain every once in a while. That's potentially to blame for it there. And really the study of choice for that type of an injury is an MRI. The peroneal tendons, in addition to dislocating or subluxating, can also tear. Again, tenderness right over the peroneal tendons. Usually it's directly behind the lateral malleolus. And sometimes you'll get this snap as people circumduct their ankle. And we talked a little bit about the lateral talar process, anterior process, and the Achilles tendon. So I'll be over at the physical examination section as well for anyone who has any questions about that. But I wanted to thank you for your time, and happy to take any questions if you have. Thanks. Go ahead.
Do you ever see compression fractures in the dome of the talus?
Occasionally, yep. It's the talus is a very hard bone, and so it's tough to compress it. It's got specialized cartilage that absorbs a lot of weight, and that's why injuries to the cartilage of the talus generally leads to long-term problems, because we don't have anything great to replace that with. But yeah, it's fairly rare to get a compression fracture to the talus. All right.
Thanks, Steve.
Thanks.